When it comes to private healthcare, name the private hospital groups in the country. You can do it. On one hand, there's Life Healthcare, there's Netcare, there's Mediclinic. Anyone else? Well, most middle-income families in South Africa are faced with an unaffordable and exorbitant private healthcare costs. The chief executive of a new entrant into private healthcare at RH Bophelo is betting that some of those people will be willing to pay for affordable quality care. This is the MoneyMakers. I'm Bruce Whitfield. I'm joined by Quinton Zunga, who is a founding partner and chief executive of RH Bophelo, which is just listed on the stock exchange. You're up 5% in a week. If you get 5% every week for a year, you'll double. You'll double the price from $10 to $20, and then you can retire. Why subject yourselves to the vagaries of the market at the most uncertain time in markets, probably since your days as an investment banker in 2008?
I think it's because we've got a compelling story, and a story that is very emotive to South Africa, because healthcare is not making many people happy. You've got private healthcare that's a little bit expensive. A little bit expensive, or a total rip-off?
I mean, let's be honest about it. I've never been able to assess whether it's the tail wagging the dog. Has medical insurance enabled private healthcare to go stratospheric, or has medical insurance protected us from stratospheric medical costs? What's your view on it?
I think, the controversial answer is that they're both culprits. Basically, the medical aid price in what the hospital charge, which is exorbitant. They put in an administrative cost, which is slightly exorbitant given their share prices now. And that comes to your bill. We think there are many other methodologies which are innovative, which the government has to consider. Practically what we're saying is that we've looked at this problem in one way, but there are many other ways. There are models such as the HMO model, which is in other countries, which are hospital insurance driven models where there is no middleman, because that's what the medical aids are. But we don't want to be dramatic like that at this stage. At this stage, what RH Bophelo is saying is that let us firstly give the country affordable hospital.
Do you have any hospitals in the portfolio at this stage?
We have a pipeline. As the structure of what we've listed as a special purpose acquisition vehicle, you go with a pipeline, and we'll be announcing our first hospital in the first month. We have a pipeline of 15 hospitals that we'll put under the platform.
Are these existing physical structures?
Existing physical operating that we are going to make more efficient. And
they're privately owned hospitals?
Privately owned, mainly family owned. So we're giving an outlet to hospitals that have been in the market that really need to be part of a bigger umbrella, but not just any umbrella, an affordable care umbrella. That's what we think is the niche market for us.
Forgive me for being facetious, but if these 15 hospitals in your pipeline were worth snapping up, wouldn't the big hospital players, the existing hospital players in South Africa, have bought them already?
That's where being us helps. The first thing is that they can't, because competition commission thinks they're too big. So they have a number of these deals that have been declined already. The last one being Mediclinic trying to acquire a hospital group in Klerksdorp. Number two, the government licensing is not that friendly for them to take over these licenses, because they're too big, and they are actually the price makers, so they've got too much power. So a group like us can actually play very nimble without the problems that the big groups are facing.
Now, when one invests in an engineering company, or let's say a construction firm, one expects to have lots of directors with engineering degrees. If you invest in a bank, you expect to look at the list of directors and lots of people with banking experience and with banking qualifications. When one looks at RH Bophelo, and I don't see too many medical doctors in the upper echelons of the management of the business. Is that a benefit or a drawback from your perspective?
We think we've got a right balance. We have 3 medical doctors out of 8.
How many were they all non-execs, or have you got an executive? You've got execs who are
all non-execs. We don't have them in the exec field, because in exec we have our COO, who's a medical equipment specialist. We think there's a nice nexus between the doctors seeing the end product and letting us transactors do the transaction. and they reviewing from a clinical perspective on the outcomes, so being the check and the balance.
Doesn't that create a bit of a tension, though, between the operations of the running the hospitals, the actual running of hospitals, and a management that could be accused at some point in the future, and I'm simply forecasting, of being aloof and unaware of the needs of the operational needs of medical professionals?
I think the tension is about who checks who and what knowledge do they have. So we allow the management to do the transactions, and we allow the executives to do the checking, and the independent to do the outright arbiter of whether what's going on makes sense. And that tension, I think it is good in terms of creating that balance, as nobody can be on their laurels thinking we've done a great job. The doctors have their professional reputation to make sure the hospitals under the group meet a certain criteria, and the transactors have the impetus to look for these transactions, execute them well, price them well, so that when they come under the platform, they're actually efficient, value accretive to the shareholders. How
are you going to attract talent? Because any business is only as good as its top talent. If you run a great bank, if you've got great bankers, you'll be absolutely fine. In a medical business, you've got great doctors, great nurses, great support staff, you'll have a great business, and you can then worry about costs and management of those costs at a later stage. You've got massive competition for healthcare talent, if I can call it that, or medical resources in South Africa.
Very nice topic that we love to talk about. We are launching our own graduate trainee program in 2 months' time. There is an absolute shortage of hospital managers, hospital finance managers, which has mainly exacerbated the problem. If you've got a new hospital and you want a hospital manager, you're not going to find them. They tend to be late age white males, which is not a controversial statement.
No, it's a fact. There's been a massive training and skills deficit over the last 20 years in South Africa.
And they tend to have skills by experience. There's no specific course that you can do to become a hospital manager, but they're the most important ingredient. I think we want to train for the nation. That's one of the innovations we want to bring, is that we want to bring a bigger supply of talent into the market, and allow everyone to reduce the cost of doing a business in healthcare.
It strikes me, and you're just far enough away so you can't reach me to punch me, so I'm going to say it anyway, that this is the Curo of hospitals. You're looking at a lower cost model. You're looking to train and upskill your own people to service the model that you're creating in South Africa. Is that a fair comment?
It's a fair comment if they give us the PE multiple Curo. I think I'll take it.
You'll take it. You'll take it.
But quite frankly, yes, it is. It's all about innovation. I think, right, most of the times we are fighting being a big pool in a big fish in a small pond. But the pond can be big. I mean, what we are talking about, we're not directly competing with the big three. We're not opening a hospital in high-end locations. We are going for the 20% of the 80% that the government is servicing, who we think should not be in government hospitals, because they're creating they're creating overcrowding there.
How are you going to keep costs down in a world where medical inflation, we're told, runs in double digits annually, and where the demand for skills is there, so it's going to cause pricing pressure on skills as well? How do you keep a lid on costs without compromising, I hate the term, but patient outcomes?
It's looking at the whole value chain, and that's what our current incumbents are not doing. Right now, it costs too much to build hospitals. You're talking about 3.5–4 million rand a bed. You are going to need to charge a lot of money to recoup that. We're talking about the resourcing, not training enough of medical professions to service the market, because it suits them well. They've got enough just for them and them, but there's nobody else. We are coming from the whole value extraction point, in that we're looking at introducing innovation in the building of hospitals, the putting of facilities, modular hospitals. You in the peri-urban, rural, you cannot build at that price. You're never going to make money, but you can put a modular at 10 or 20% of the cost. And
what's a modular? What's a modular?
So this
hospital?
is a pre-built hospital that you just drop.
So prefab.
Yeah.
Okay.
Yeah, so those kind of innovations are the things that we are excited about.
Have you been to Lesotho? Have you been to Maseru and seen the Netcare Government of Lesotho
Yes, I
joint
have.
venture, which Netcare holds up as this great beacon of public-private partnerships,
Yes.
because it's a superb world-class facility in Lesotho, except Lesotho's medical budget went into funding their part of that, and the rest of the public healthcare system in Lesotho has suffered as a result. Would your system be more applicable in that market, perhaps, than having the equivalent of a private hospital we could go to within a kilometre or two of here?
I think so. I think it'll be, this story is not just a South African story, healthcare, that we're talking an African story, we're talking an emerging market story. Right now, it is much cheaper for you to fly to India, get a procedure done, stay in a hotel and fly back than getting the procedure done in South Africa, which to me says anecdotally low-cost hospital provision is possible. It's just that South Africa hasn't innovated enough to think that way. And if we come with novel ways to deliver patient care at a much cheaper product price, then we will definitely be able to roll out in the rest of the continent the same model that we're trying to do here. So yes, I think that's one of the things that we're going to look for in the medium term.
First hospital within a month.
Yep.
15 by when?
We think first up to the month, when we're announcing this first hospital, we're also announcing another 4 that we want to complete by end of the year. And then the rest of the 5 first half. So 15, you're talking by end of next year.
I'm looking forward to watching the progress. It's going to be really interesting. Quinton, thank you very much indeed. Quinton Zunga, who's the founding partner, chief executive of RH Bophelo. Who was RH Bophelo?
It is an ironic statement that we hope will tell the market at the right time. It means the same as some few people we know.
It doesn't mean Mediclinic. It doesn't mean Netcare. It doesn't mean life.
I think it means life. So
there we go. It means life. Oh, he's coming out fighting. There's Quinton this evening. There will be more stories about healthcare investment. And also, it's absolutely critical. It's in everybody's best interest as South Africa, as a developing market, to have greater choice. You go into Rolls-Royce hospitals, you're paying Rolls-Royce prices. It's now time for the Toyota Taz of hospitals. Very reliable, very dependable, and one that is going to get you to your destination. We hope. We watch this space. Thank you for watching The Moneymakers. Good night.